Friday and welcome back to Belly to Baby. We are in week 34 right now, and I only remember this. I had to look up what size baby I had, and I think it was a coconut at this point. And I've been measuring the progress of this series based on those fruits as we go along. But we're here joined by Dr. Eric Strand. Thank you so much for being with us today.
No, happy to be here.
We were chatting beforehand. You are the lone male physician in the practice full of women that we have been circulating around for quite some time. So,
that is correct.
But you're a dad of 4, so between your job and the 4 kids, you know this drill quite well.
Hopefully, yes. I hope so.
Well, we're today talking about, I think, a topic that's going to be of really great interest to a lot of our viewers, because it's a source of fear, I think, for a lot of us too, an unknown, which is the mode of delivery, whether you have a baby vaginally or if a C-section is required. And I think, first of all, there is a lot of, I think you hear all the time, oh, you don't want a C-section, you don't want a C-section. I've had a lot of friends who've had very successful C-sections. Why is it that the vaginal delivery is, I don't know, is it preferred or is it a better way to go?
Sure, I think all things considered, there are a variety of reasons why a patient would want to have a vaginal delivery. Certainly the recovery after that delivery tends to be much less complicated. So the delivery itself is, you tend to have less blood loss, less pain after the delivery, a faster return to your typical activities. And so for a variety of recovery reasons, a vaginal delivery is preferred. There's also a little bit of benefit to the baby from a vaginal delivery. So in particular, babies who are born vaginally tend to have a little bit of an easier transition breathing, and so they're less likely to have some of these episodes of rapid breathing that might require some additional observation in the nursery or even the NICU. And so from an elective delivery standpoint, typically you'd always try to steer somebody towards a vaginal delivery if they're an appropriate candidate.
Gotcha, and I should note that I have this entire list of questions that I started typing out yesterday, and I could have gone on for quite some time. So I know there are going to be more questions than what I have on my list. So if you all have any questions, please don't hesitate to chime in. Put them in the comments and we'll get to them as soon as we're able. And we do monitor those questions throughout the week as we go on. So if ever you have something and you're rewatching, we can get back to that. So who decides ultimately whether or not, could I walk into my doctor today and be like, you know what, this whole pushing the baby thing, I don't think it sounds so hot, and I would really rather have a C-section.
Yeah, you would be like Britney Spears.
Really? Well, and that's how I reassure myself that I'm ready to have a baby, is that they sent Britney Spears home from the hospital twice with children, so I'm like, it can't be that bad. I've got to be better equipped than that. But can you, aside from Hollywood, is that something that you can do, or how would you counsel a patient who came in and said, this is not my jam?
Yeah, no, so I think one of the big questions to answer if somebody came in and was asking for just an elective cesarean delivery without any medical indication for that, is we often want to dig a little bit into, well, why are they asking that question? And to make sure that they have a realistic understanding of what is a vaginal delivery, what is a cesarean delivery, what are the risks, what does it feel like? I feel, sometimes a patient has a fear of a vaginal delivery, and I think we want to make sure to hopefully allay some of those fears with the information that we have. There are, I would say, potential benefits to a cesarean delivery. So certainly the risk of damage to the pelvic floor musculature, so things like urinary incontinence or leaking from the bladder. While those things aren't very common after a vaginal delivery, they're certainly more common after a vaginal delivery than after a cesarean delivery. So in that circumstance, if somebody really weighed that particular complication, they might choose to have an elective cesarean delivery. The more cesareans somebody has, the more complicated they get, and so that is certainly something to consider. If somebody is having their only child and they've decided that for them a cesarean is the best way to deliver the baby, then we would certainly have that discussion with them. But if somebody's planning to have 4 or 5 babies over the course of time, having 4 or 5 C-sections is probably not in their best interest, and so we would want to help them understand the risks of each of those subsequent cesareans that they might be destined to experience.
Yeah, and I know that with recovery, it gets a little harder each time. And maybe that's just knowing that, I mean, the people I know who have had repeat cesareans have had, I think the first one has been emergent in all cases I can consider. And then they've had other children to take care of after subsequent cesareans. So, I mean, you can't pick up your 2-year-old as easily when you were trying to recover from your second C-section. So that may be.
Oh, sure. Yeah, and I think, the recovery piece, especially for people who are at home with other kids, is certainly a big one, because as you said, you're not going to convince your 2-year-old not to clamber up onto your lap, and when they do that, you're going to want to be helping them do that. And so, if you can start the sequence of vaginal deliveries, it keeps you away from having some of those complications that occur from multiple cesareans.
You might hear the helicopter in the background, just to give you some indication of where we are. We are actually in the labor and delivery room at Barnes Jewish Hospital. This is all part of the Women and Infants program at Washington University, Barnes Jewish, and St. Louis Children's Hospital. So that whole strip of buildings you see in the Central West End, and we're in this building for a little bit longer until you guys get the benefit of brand new and shiny right down the street.
I know, so that'll be great. We're very excited.
Very exciting that that's coming up here soon. When you talk a little bit about the factors you consider when someone comes in and says, I want a C-section. What about someone who comes in? I mean, there are factors that are obviously C-section is the better way to go. So what kinds of things do you look at as a physician when you are recommending to a patient, we really need to consider?
Sure. I think in that setting, there are sort of two things to consider. So one is for somebody who, let's say they're having their first baby and they're here and they're in labor. Well, we know that a percentage of those patients will end up with a cesarean delivery, most commonly for what we would call an arrest disorder, which essentially means you dilated to a certain amount and you couldn't dilate anymore, or let's say you got completely dilated and pushed and couldn't push the baby out, and the baby was still too high for us to try to assist a vaginal delivery. So those two, those arrest disorders are a common reason why somebody kind of coming in labor thinking they're going to have a vaginal delivery might end up with a cesarean. The other would be the baby, and how does the baby look on the monitoring that we do. And certainly sometimes if the baby isn't tolerating the labor and their heart rate is showing us changes that would make us concerned for their safety and well-being, then that might be an indication for a cesarean. So some of those conversations happen during the labor process. Other conversations that happen in the office tend to involve, for instance, patients whose babies are breech. So if the baby isn't head down, then it is a safer delivery for the baby for them to be delivered by cesarean as opposed to an attempt at a vaginal birth. People have had certain types of uterine surgery, particularly, for instance, somebody who's had a complicated fibroid removal, a benign muscular tumor of the uterus. That can weaken the uterine wall and increase the risk of that wall separating during labor. So oftentimes those patients will be counseled that it would be safer to have a cesarean delivery. The placenta can be in front of the baby. Obviously that makes vaginal delivery impossible because we can't deliver the placenta first, so those people require a cesarean delivery. So there are certain very specific things in the prenatal care that we would identify that would certainly lead us to recommend a cesarean for a patient.
Gotcha. And we have a question?
Yeah, Jocelyn wants to know, if you have a second C-section, do doctors typically cut where the first scar is, or do they cut above or below the first incision?
Yeah, no, great question. So typically speaking, we'll try to use the same incision, just from a cosmetic standpoint. I would say there might be unusual situations where the scar is in a different place, or maybe we don't typically do an up and down scar, but if somebody had an up and down scar in their first cesarean, we might talk to them about doing a transverse incision because that tends to heal better and is associated with less post-operative pain. So we might not use that same vertical scar. So we would definitely have that conversation with the patient, but typically, yeah, you're going right through the same incision.
I did half jokingly ask my doctor if we wind up needing a C-section, if they could just install a zipper. Yeah. So that for any subsequent babies, you could just go, whoop, and you're good to go. But apparently that hasn't been invented.
Yeah, we have not invented that yet.
Well, get to work. You'll be a bajillionaire. What is the difference? You hear the difference between an emergency C-section and a planned C-section. Clearly, one is emergent, one you anticipate. But is there a difference in protocol and practice between the two?
So I think for a planned cesarean delivery, things feel very controlled. You come in usually a couple of hours before your planned surgery time. Anesthesia would see you, oftentimes give you an anesthetic in your back, a spinal or an epidural, so that you would be awake during the delivery, which is very desired by most patients, obviously, but then should still be comfortable during the surgical procedure. During the course of somebody's labor, we oftentimes may find, because of a baby's heart rate issue or because somebody has stopped dilating, we may find that we're going to the operating room. Most of the time, those aren't necessarily emergent. Everything looks fine. We just have to make a decision that the baby's not going to come out vaginally, and because of that, we'll proceed with the cesarean. But usually, that still feels like a relatively controlled scenario. I'd say very rarely are there situations where it's an absolute, we have to get the baby out in the next 5 minutes, and so we're running to the OR with the patient and her spouse or her significant other to do a delivery in that expedient a fashion. Typically, that's because, again, there might be some abrupt change in the baby's heart rate that would indicate that we needed to move more quickly.
Okay. And once you've had one C-section, this is kind of back to Jocelyn's point too, do all subsequent babies have to be delivered via C-section? Or I've heard the phrase VBAC before.
Yeah.
Vaginal birth after cesarean? Is that right? Okay.
Correct.
So is that an option? Is it recommended? How do you decide whether or not a patient is?
Yeah, no, that's another great question. So I think one of the big pushes that a lot of obstetricians have, here and around the country is trying to select those correct patients who would be good candidates for a vaginal birth after cesarean. So there are most of the time, we make a transverse incision in the uterus. That incision heals better in the uterus and is associated with less blood loss, but that also decreases the risk of having that scar separate in a subsequent labor. And so people who have had a lower transverse incision on their uterus are reasonable candidates to then try to have a vaginal birth after a cesarean delivery with their next pregnancy. People who have had an up and down incision in their uterus, because that affects a different muscular portion of the uterus, are at a higher risk of having that scar separate, and so we would not recommend that they labor because you have an increased risk of having an emergency complication from that scar separating. A lot of times we try to do our best to sort of help people understand what their chance of success would be. And so why you had your first C-section is a pretty significant factor there. So if you had your first cesarean delivery, let's say because the baby was breech and you never really got a chance to have a labor, well then it's almost like you're starting from scratch, and so your success rate in that situation is pretty good. If you had your first C-section because you got all the way dilated and pushed for 3 hours and still had to have a C-section after that, well then your success with the subsequent delivery trying to go vaginally may not be as successful because that might be a sign of sort of a mismatch between the size of the baby and the size or shape of a patient's pelvis. But even many of those patients will still be reasonable candidates to try. They may not have quite the success rate that other patients may have, but certainly, for most patients, I feel if you feel like their success rate is 50, 60, 70, 80%, which it might be, then it's usually worth giving the vaginal birth after cesarean a try.
Really, that's interesting to me because I would have thought if you'd I figured you'd want to pick one method and stick with it to the best of your abilities, but there are still benefits of having a vaginal delivery after a C-section, even though you've already got whatever physical complications have or would have come from the C-section.
No, correct. I think, so if you're successful having a vaginal birth after cesarean delivery, then you still get all the benefits that you would have had from a vaginal delivery in terms of, again, less blood loss, faster recovery, etc. One of the issues with people who have multiple C-sections is that each cesarean delivery tends to be or can be more complicated. So the more times you've been operating on somebody's abdomen, the more scar tissue there can be, the longer it can take to get the baby out, the increased risk of hemorrhage, excessive blood loss, even additional surgery. The more C-sections a patient has the increased likelihood the placenta may implant abnormally, which can be a very big deal and a very big risk for blood loss. and even require sometimes a hysterectomy after a cesarean. So those subsequent cesarean deliveries really do have some significant risk. So if somebody's a reasonable candidate to try to have a vaginal birth, we would certainly encourage that.
Okay. Are there questions that women should be asking their physicians before delivery day, even if there really isn't an indication about just understanding what a cesarean would entail versus a vaginal delivery, even if everything looks like it's lined up to go correctly?
No, I think that is definitely a great question for any patient to talk about with their doctor, because I think particularly for women who have had uncomplicated pregnancies, you sort of oftentimes go in assuming that everything's been fine, so I'll end up having a vaginal delivery. And we know that depending on the population, 10 to 15 to even 20% of those women will still end up with a cesarean delivery for some reason. And so I think sometimes patients can be a little bit caught off guard, that they went to their birth class, they talked about vaginal delivery, they've been sort of getting psyched up for that experience, and then all of a sudden at the last minute they feel like they've been thrown this curveball.
I've checked all the boxes.
Right,
yes,
right.
Yes.
And so then that can be a little bit disappointing. And so I think having a good understanding of both modes of delivery is really important in case you end up experiencing one or the other.
Well, and I think one thing you mentioned earlier, and it's something that has been weighing on my mind, I'm not quite to the point of no return. You said 36 weeks is when you want to really care about whether a baby is head up or head down. Okay, so I could swear to you there is a head under my rib cage right now. I don't know this for sure, but at 36 weeks when you start checking that, what does it matter? I mean, if the baby is not head down, is there something you can do to encourage it to flip, or are you at that point just looking at C-section?
No, so I think in most practices you would be offered what's called an external cephalic version. And so that is a fancy way, that's a fancy way of saying we try to flip the baby. And so usually we would choose to do that at around 37 weeks, because at 37 weeks somebody is considered term. And so if there happened to be a complication of the procedure, which is quite rare, but if it did happen, we'd feel comfortable delivering a patient if we had to. Typically in that situation, if somebody's baby is still breech and the head is up, we would bring them to labor and delivery. Oftentimes you might even get an epidural to help with the discomfort that you might experience as we're trying to manipulate your belly. We give you some medicine to help relax the uterus, and then it sounds just like it is. We're kind of with our hands on your belly, following with ultrasound, seeing if we can get the baby's bottom kind of up out of the pelvis, so we can do a front flip or a backwards roll, or one or the other, to get the baby.
Some gymnastics.
Right, exactly, to get the baby to flip around. The uterus is egg-shaped, and so most babies feel like they have more room if they're head down or head up, so being sideways is not a particularly comfortable spot for them, particularly as they get bigger. So usually if you can get the baby kind of just past that point where they're sideways, they'll usually complete the flip. So obviously, as I mentioned before, if a baby stays breech, we would typically recommend a cesarean delivery, and so your chance of having a vaginal delivery for a breech baby is essentially zero. Obviously that's much, much higher if we're able to flip the baby. And so that doesn't mean that you would get induced that day at 37 weeks. If you went, if we were able to flip the baby, then you would go home and we would await labor, or potentially you'd get induced later on depending on how far you went. That's right, I hope the kid doesn't flip back. But that's another reason why we choose 37 weeks, is because once the baby's that size, if we're successful flipping them, typically they won't flip back.
Pretty confined. Yeah. We have another question?
Yeah, Tabitha wants to know, in general, how many C-sections can a mom have? Is there a certain cutoff, or at every mom 4 is the maximum, or is it different depending on different conditions?
No, sure. Another good question. I would say, as we've seen the C-section rate increase over the past 20 or 30 years, it's not uncommon that we have women who might be having their 4th or 5th or 6th C-section or even more.
Really?
Yeah, so not many people are having 6 kids. But that being said, there are women who have more. I guess the answer to the question for Tabitha is there's no maximum number. I think it is important to know, like I said before, the risk of complications from surgery increase with each subsequent cesarean delivery. But if somebody has decided that 6 is the right number for them, then we would certainly care for them and do our best. But I think there's been no evidence that beyond a certain number becomes exorbitantly risky, for instance, to the patient or the baby.
Interesting. Well, we'll have a show in a couple of weeks where we talk about the physical recovery from childbirth, whether it's via cesarean or vaginal delivery, and another about the mental recovery process. But just kind of as a nutshell, can you talk a little bit about the recovery process for a C-section versus a vaginal delivery and what separates the two? You talked about it a little bit earlier, but
yeah, no. So I think that's part of the discussion that goes in for these patients who ask for elective cesarean deliveries. I think is reminding them that even though we do cesareans appear every day on labor and delivery, that is still a major surgery. And so there is some significant recovery that is associated with that. In the immediate hospital phase, typically having a cesarean delivery will add 1 to 2 days to your hospital stay, just because we're keeping an eye on various things. Obviously, people's, they're a little bit slower to walk and to, feel a little bit more like themselves. Predominantly from the incision in their abdomen. So I'd say most people's recovery is sort of limited by how that incision feels, and not so much necessarily what we did on the inside as part of the actual cesarean itself. For a cesarean, I'd say most people go home, using a variety of different pain medicines. So you would get pain medicine not just in the hospital, but also prescriptions for those when you go home. I generally tell people, quite honestly, it's much more about listening to your body and how it feels than any sort of proscriptive, you can't lift this amount of weight or that amount of weight or things. I think patients after cesarean deliveries are probably more limited by the discomfort that they have than necessarily a number. So for instance, you put quite a good amount of force on your incision when you call for sneeze, and clearly we don't tell you that you can't call for sneeze. So I think what that means is most people, when they go home, are probably fine to do what they would normally want to do. Lift the baby in the car seat, get a gallon of milk out of the fridge. You're fine to do all of that, go up and down stairs. We usually will tell people they should avoid driving for at least as long as they're on the narcotics, because if you're on a narcotic pain medicine, that's might influence your decision making a little bit. So we'd rather not have you behind the wheel of a car. But I feel like most people are generally off those stronger pain medicines within a week or two, and then might be on something like Tylenol or ibuprofen for another week or two after that. And generally speaking, by about 3 or 4 weeks, they're complete with their pain medicine.
Sure. And then there's also the difference in how the baby is handled. I'm gonna take you along my train of thought on this. When you're talking about being on pain meds, can you still breastfeed?
Yes, absolutely.
Okay. And in the operating room, in this case, rather than the delivery room, do you call it the delivery room or the operating room?
The operating room for a cesarean, yeah.
Okay. So when you're in the operating room, I know there's been a huge movement, especially here at Barnes Jewish, to really give women the opportunity to experience a lot of those moments right after childbirth as the same as they would if they had delivered vaginally. So can you hold the baby right away? I mean, what happens when there's, I believe, a sheet up, if I've seen pictures. Yeah. There's a sheet here, and then you're numb from, I would hope, numb from here down. And then baby comes out, and then can mom hold the baby, or how is that?
Yeah, no, so I would say that's been a big change, that I've seen in my, 10 or 20 years of practice, in terms of really treating the operating room like an operating room, where the baby gets whisked away and just sort of held over in the warmer until mom is ready to get wheeled out after the end of the surgery, to where now we'll deliver the baby. Generally speaking, mom will see the baby pretty much immediately. We'll hold the baby up, get the baby cleaned off, and then as long as mom is feeling okay, she'll have the baby right up on her chest, so do the similar sort of skin to skin connection that we would do in a vaginal delivery. She just got the baby sort of underneath the drape that we are using to keep our part of her abdomen sterile while we're doing the surgery. But she can be up there with the baby. She could breastfeed the baby while we're doing the surgery. As long as she's comfortable, we're happy to have that happen. Sometimes if during the surgery the mom may not be comfortable, or maybe she's feeling a little nauseated. We've had dads in the back do skin to skin, just unbutton their shirt and have the baby next to them. So I think there's a lot of opportunities to sort of duplicate those experiences that you typically associate with a vaginal delivery at the same time you have a cesarean.
And one of my colleagues who's had 3 children, never had a C-section, she asked a question that I thought was really intriguing and something I'd never considered. It was after last week's episode or maybe it was the week before, we were talking jokingly, but seriously at the same time, as so many of these things are, about the giant pads that you get after you have a baby. Do women bleed the same way after cesareans as they do after vaginal deliveries?
Yeah, I would say they often will. I'd say particularly for somebody who has a cesarean after a labor or in the course of a labor, where let's say you stop dilating and had a C-section, so where the cervix is open, then a lot of that blood that comes from the uterus contracting down will continue to flow through the vagina. If you have a scheduled cesarean delivery and your cervix isn't open that wide, then you may not notice quite as brisk or the same volume of bleeding that you would have noticed during a vaginal delivery. But we typically counsel people that the duration of their bleeding is probably going to be about the same, whether they have a vaginal delivery or a cesarean.
Right. Anything else about the C-section or mode of delivery that we haven't talked about?
Not that I can think of off the top of my head.
Well, I just wanted to ask before we switch gears, because one topic we haven't discussed at any length in this series, but I think would be great to address here, is induction. And that's another thing that I think a lot of women, I know that in your mind you want to go into labor naturally and have the baby I think the word natural gets a weird connotation. You want your body to decide when it's time to have the baby and to do so in under 40 weeks. But if it doesn't, when do you decide whether or not to induce labor, and how does that happen?
Yeah, so I'd say you have a group of patients where that discussion might happen earlier than you would anticipate because there's some medical complication of pregnancy. So clearly there might be indications where, because a mom has a high blood pressure disorder or something else going on, that we might discuss inducing her labor earlier than her due date because of some of the consequences and health risks of those issues. Assuming that everything is fine and that you don't have one of those medical conditions that you're concerned about, then there's been a big push to really forbid elective inductions before 39 weeks.
Okay.
And that's been a big national push through our national organization and really hospitals all across the country. Because we know that babies born electively at 37 weeks and 38 weeks do not do as well as babies who are born at 39 weeks. So most places will have a very hard and fast rule that nobody would get induced without some medical indication before 39 weeks. I think the discussion to have with your doctor or your care provider is sort of what happens as you hit that 39-week point. And I think in our practice, we'll sort of talk to patients about what their desires are. As you mentioned, a lot of women, are just kind of want to let their body take over. And certainly from a labor efficiency standpoint, your labor will be more efficient if you go into labor. That was my next question. Yes, I wondered if that was I always wondered if that was true. Yeah.
It worked more easily.
Yeah. Then if we bring you in and we induce you and we're starting from scratch, it's going to take a while to get you into labor. Which is very different than if you show up contracting, you've broken your water, and you're already sort of halfway through the process on your own. The risk to the baby is very small until you get to about 41 weeks. And so if you get to a week after your due date, the risk of issues for the baby does begin to climb. And so I feel like the standard in a lot of places is to at least offer and really encourage people to consider being induced by that 41st week. But in certain situations, if you have a patient who is very adamant they would not want to be induced, we might let them go even a little bit longer. We would do some assessment of the baby to make sure that we felt like that was completely safe to do.
What are the hazards that come along with going beyond 41 weeks?
So there's a risk of stillbirth for any pregnancy, no matter where you are in the pregnancy. And that's obviously the most significant complication that could happen. That risk begins to increase a bit after 41 weeks. And so sort of the lowest point of risk of stillbirth is around that 39-week point for people who have a single baby. And so that's why 39 weeks is sort of a little bit of a magic number. The risk doesn't change substantially until you get to about 41 weeks. And so that's where we would want to do some assessments of the baby to make sure that we felt like it was perfectly A-okay to leave the baby in.
Gotcha. So if you had a woman who came into your office in the heat of August and said at 37 weeks, get it out, you'd say, find air conditioning for 2 more weeks.
Right. Air conditioning, maybe a pool. But yeah, we wouldn't electively induce them. I'd also say, there's a lot of debate about, well, does being induced increase your risk of a cesarean delivery? I feel like that's a question that we commonly field from patients. And I feel like that was based on a lot of older studies that looked at, well, what happens to our patients, let's say you're 40 weeks, what happens if I induce you today, or what happens if you were in labor today? And so if you compare those two groups, the people who got induced did have a higher cesarean delivery rate.
Okay.
But the problem is that that's not our choice, right? Like that day, you can be induced or you can wait. You don't get to be induced or be in labor. And so if you look at, well, what happens to those people when you wait? Some of them might get induced a week later because they didn't go into labor. Some of them might go into labor on their own. Some might get induced because they developed a complication like high blood pressure or preeclampsia. So, some complications can arise in that interval that you're waiting. And so if you really look after 39 weeks at people who get induced versus the people who wait, there really isn't any difference in their cesarean delivery rate. And so I think that at least allows some discussion to occur between a patient and her provider about what her wishes might be in terms of being induced versus waiting for natural labor to occur.
And I do have one more question as it relates to both induction and cesarean sections. And that comes down to the size of the baby. First of all, are you able to determine before baby's born how big the baby is? I mean, I know you can't tell just by looking at someone, but can you get a pretty good guess as to whether or not you're dealing with a really big baby?
Yeah, so unfortunately, I guess there are two pieces to that puzzle. So one is we're not particularly good at estimating the size of the baby. Whether it's your guess as to how big you think the baby is.
It's huge. Sorry. It's probably not. I think every pregnant woman at this point feels like it is a monster. Yes.
But your guess, my guess, when you come to the prenatal visits and we're measuring your belly, a guess that we would have based on ultrasound. So if you go and get a formal ultrasound to assess the size of the baby, as you approach your due date, that ultrasound could easily be off a pound or 2 in either direction.
Oh, wow.
Which is a lot of variation.
Yeah,
so I think because of that, we typically don't get too worried about the size unless we truly think the baby is extremely large. The other piece of the puzzle is that everybody's pelvis is different, right? And so some women who have a pelvis that is shaped for childbirth might have an 8 or 9 pound baby and do completely fine. And you'll see other women who end up having a cesarean delivery because their cervix stopped dilating when they were 5 centimeters and the baby's only 6.5 pounds. So it's really more about the match between the size and shape of the baby and the shape of an individual patient's pelvis. If a patient has had an uncomplicated pregnancy and we think the baby's large and we get an assessment and the baby is weighing 5,000 grams, which is about 11 pounds, that is a patient we would generally counsel about a cesarean delivery. Because if we think the baby's 11 pounds, even if we're off, it's probably still 10 pounds. And the likelihood of somebody having a successful vaginal delivery with a baby that large is pretty remote. And so those are people that we would talk about perhaps doing an elective cesarean delivery for.
And as most pregnant women know, you're given money insights by people in the checkout line. And there was the guy the other day who saw me and he goes, "Did you hear about that woman who delivered a 16-pound baby without any drugs?" And I was like, "No, I don't want to be her." Sorry, I believe we have another question.
Yeah, Jocelyn wants to go back to the procedure of the C-section. She said her mom told me something about being vacuumed during a C-section. Is that still a thing?
That sounds very odd. Okay.
No. So it's actually, it's
you
not
need
all
to
that.
work on your terms.
It's not all that odd though. So I think many people know that we have certain instruments that we can use to help facilitate a vaginal delivery. So a vacuum, which is like a little suction cup applied to the baby's head to help guide the baby out.
Okay.
Forceps, which look like kind of spoons or salad tongs that we kind of help to pull the baby out. So those are more commonly used in a vaginal delivery. However, there will be times during a C-section where if you are having a hard time bringing the baby's head out of the incision, either from the skin or the uterus, that you may consider applying a vacuum in that instance to the baby's head to help guide the baby out.
That is so much less horrifying than what I was expecting. Okay.
Yeah, no, I mean, I would say most C-sections don't involve the use of a vacuum, but certainly if there was a challenge extracting the baby, then you might consider doing that to help expedite that process.
Interesting.
Yeah.
All right. Well, and I believe we have one viewer who's been with us throughout who told us, this is Jocelyn, who told us that she is due to have her baby this week. So thank you all so much for tuning in. And Jocelyn, please keep us posted. I believe it's legal to ask you to do that in your own terms. If not, this video is suddenly going to disappear from Facebook and you will never know it existed. Dr. Strand, thank you so much for joining us. We really appreciate your time today.
My pleasure.
This has been super informative. We'll be back here next week at 1.